This is probably one of those posts where I point out that I'm not your medical director, I don't sign your paycheck, and I have nothing to do with whether you continue your employment or not. So use your own best judgment and do what you think is right. With that being said, you were sent to the Riverside bike path on a report of a bicycle crash. Of course, it's like any call on a path away from road signs. It takes forever to get the caller to figure out enough landmarks for you to find the call. In any case, after your irritatingly long response time, you find a 50-year-old male who was spending his morning riding several $1,000s of carbon fiber. For whatever reason, he was forced to swerve at speed off the concrete path. Off the path, he struck a bench and was thrown forward off the suddenly stopped bicycle. You find him awake and alert, but in obvious distress. He's cradling his right arm and complaining of severe right shoulder pain. Making a long story short, because I know you don't want to spend all day watching this, he has a demolished right shoulder, probably a fractured clavicle, maybe dislocated, maybe humeral or scapular fractures. It's all a tender, swollen, discolored, and abraded mess. His distal sensation and circulation are intact, but the shoulder is just wrong. Interestingly, his helmet is abraded and cracked as well. The patient denies loss of consciousness and denies neck or back pain or tenderness. Do you mobilize him? Collar on board? Just collar? Nothing? This is Angry Bill with pre-hospital wisdom, where we understand medicine's medicine, but medics and EMTs have specific skills and knowledge. Subscribe if you agree or like this content. We continue. The spinal immobilization criteria in my system are pretty similar to the next criteria. We don't need to immobilize if there's no focal neuro deficit, no midline spinal tenderness, and a reliable exam. Reliable exam includes, in part, stuff like no altered consciousness, no intoxication, and no distracting injury. That's what I want to talk about. I want to talk about the concept of distracting injury. He has no neurodeficits, no spinal tenderness or pain, and is not altered or intoxicated. Does this patient's shoulder constitute a distracting injury? The Nexus literature defines a distracting injury as a condition thought by the clinician to be producing pain sufficient to distract the patient from a second neck injury. The Canadian C-spine rule describes distracting injuries as injuries that are so severely painful that the neck examination is unreliable. Common examples include long bone fractures, visceral injuries requiring surgical consultation, large lacerations, degloving injuries, crush injuries, large burns, and injuries producing acute functional impairment, whatever that is. Okay, we got it. Stuff that hurts. Heffernan added any painful chest injury, and a Greek guy whose name I can't pronounce showed that the 4% of patients with painless neck fracture all had rib fractures and or severe chest tenderness. So add chest injury to the description of distracting injuries, I guess. All of the listed injuries above vaguely irritate me. The authors made a good faith attempt to objectively describe injuries that are likely to distract a patient, and I think that they failed. They failed because the task is impossible. I get that a femur fracture, long bone fracture criteria, is probably a distractor. But what about a distal tibia fracture? I drove myself to the ED 4 hours after fracturing my own distal tibia. I wasn't distracted. How severe does a burn have to be? How much degloving do you need? What's severe chest tenderness? Are pelvic fractures, not being long bones, never distractors? What the hell constitutes a large laceration? Speaking of hell, what the hell is acute functional impairment? An injury that the patient doesn't want to move? If you ask me, any testicular injury should be on the list of distractors. Why is that not there? Everything is still subjective. Sorry, but you still have to make a decision as a clinician in your patient's best interest. Is the patient distracted by his or her other injuries? Answer that question. A distracting injury is something that's so painful that the patient can't pay attention to other injuries. They feel nothing but the distractor. It has 100% of their attention. So how can we decide where that line is? I have an idea. This is something that I've done for years. It's not supported by literature, but see if it makes sense to you. And remember, I'm not your boss. Don't let me get you fired. Check if the patient's distracted. Do this in blunt trauma because who still immobilizes penetrating trauma? So what you want to do is pinch one of the patient's fingers without them being able to see the finger. They have to feel the pinch. Cover their hand with a blanket, cover their eyes, whatever makes sense to hide their fingers. Squeeze a finger about as hard as you do when you check capillary refill and hold it. Ask the patient which finger you're squeezing. If they get the answer correct, especially if you repeat the test with a lighter and lighter touch, they can separate the pain from their other injury from their other neurological inputs. They're also likely to be able to recognize midline cervical tenderness when asked. They have They are demonstrably not distracted. Thus, if they can identify which finger you're touching, they probably don't have a distracting injury. What do you think? Does this make sense to you? The patient described in the beginning of the post passed a squeeze test. He could even identify which finger was being lightly scratched with a fingernail. I decided that even in the face of a devastated shoulder and cracked helmet, I felt like I could trust his denial of spinal tenderness. We had to talk about immobilizing him, paralysis, and distracting injuries while I was starting an IV. He agreed that immobilization was unnecessary and also agreed that he would like an excessive amount of analgesia. So I didn't immobilize him. There are other patients who are in such pain that they can't even pay attention to the fact that you're trying to test them, however. They're just screaming in agony. Those patients have distracting injuries and get immobilized in my bus. If you're concerned that a distracting injury is present, check to see if the patient's distracted. It's simple. You made it this far, so you may as well subscribe. Comment your thoughts below, and until next time, this is Angry Bill with Pre-Hospital Wisdom. Stay safe.